The title of my project is Nowhere to Go, Budgetary Politics and the History of Deinstitutionalization in California. Nowhere to Go is a fitting title because I'd wager that describes how most of you feel right now as you have to sit through just one more. Don't worry, it's on a light topic. I'm talking about mental institutions, so everyone's going to have a good time. In 1977, State Assemblyman Frank Lanterman introduced an assembly bill to break up the State Department of Health. You see, a few years prior, all state health and welfare functions were consolidated into this one department, ostensibly to reduce costs to the state, increase efficiency, and improve the quality of services provided. Instead, said Lanterman at the time, the consolidation has resulted in chaotic management, unnecessary layers of review, and endless delays in implementing legislative mandates. Programs are deteriorating to the point that public opinion is shattered. It's time to find a simpler way. And that's it. Lanterman was referring to the final step in a series of transformations to the state services system that began in the 1950s. Beginning with the Short-Doyle Act of 1957, California started trying to shift to community-based mental health programs and away from the financially burdensome and unpopular state hospitals. Through the late 1950s and 1960s, the funding for community programs steadily increased, and a wave of reforms beginning in the late 1960s raised hope that community centers could become the primary means to care for the mentally ill. Finally, it seemed like a new model of mental health care seemed within reach of the state of California. On top of that prospect, Lanterman was a key advocate for the very policy changes he now vocally sought to undo. As a strong voice pushing for institutional reforms, and an author of the Lanterman-Petra Short Act of 1968, which ended involuntary commitment of the mentally ill, Lanterman helped create this new state services system. So why the sudden regret? Now, as residents of the Bay Area, which is renowned for its large homeless population, many of us witness and perhaps experience the cause of Lanterman's buyer's remorse every day. Decades later, California's mental health system is still in a state of crisis as a result of the catastrophic changes that occurred to state services during this period. The statistics are uncomfortable. Conservative estimates place the number of chronically homeless who have at some point experienced severe mental health problems at above 50% in California. An estimated 25% of inmates have some form of untreated mental illness. Most strikingly, California is estimated to have one available psychiatric inpatient bed per every roughly 6,000 residents. That sounds worse when you consider the fact that the recommended ratio is 1 per every 2,000 residents, leaving the state woefully unprepared to aid its citizens with mental illness. These statistics all come from the California Hospital Association, by the way. Increasingly, those for whom our hospitals no longer have any room are ending up either homeless, in prisons, or invisible entirely. My research aims to understand the transformation of mental health services and what exactly went so wrong in California through a historical lens. Just how and why did policy changes in the middle of the 20th century take a previously competent, if not stellar, state mental health system and turned it into one incapable of supporting the very people for whom it was built to care? The mechanics of the failure are well documented. A massive decline in hospital capacity for those with mental illness was met with no increase in funding for community mental health programs, and these combined with a decline in state oversight of the community facilities. Rather than retread that territory, my research looks at the intentions and motivations of the important entities involved in the hospital closure conversation. It's clear that this transformation to the mental health system failed the patients in the closure process. Who was looking out for them? My efforts to understand and report on those motivations brought me to different archives around California that had something to say about this time and these events in California history. This includes documents from a variety of sources listed here, including officials from the governor's administration, the state legislature, the medical community, and public opinion through local newspapers, as shown. After collecting anything relevant to the closures, I assigned different categories to each document based on its author, whether they were members of the governor's administration, legislature, healthcare community, or the public, whether they were in favor of the closures or opposed, and the nature of the concerns behind their support or opposition. Not all authors were explicit in their concerns or motivations in the process. Interpreting their writings required tracking words that were closely associated with different sorts of concerns. No? Okay. Oh, there we go. For instance, documents that included mentions of inefficiency and mentioned the state budget repeatedly revealed an author more concerned with the money that would be saved from the closures than they were with the quality of care of the patients. This chart here, does not include figures from the legislature and from people among the public. Instead, it lists just the executive branch and the medical community, because whether you belong to the executive branch or the medical community was one of the biggest indicators of where you fell in the debate on whether to close these hospitals or not. This system of organizing these documents helped shine a different light on the debate surrounding the hospital closures. Notably, the governor's administration, whose representatives were arguably the most vocal proponents of the institution closures, rarely discussed the issue in terms of quality of care for the patients or concerns for their families. As you can see here, the terms that match up more with concerns with budget or money issues are very common in the documents provided from the administration that were in favor of the closures. In contrast to that, we have lots of words such as quality of care and the patients and the mentally ill, and they didn't appear as much in any of the documents, whether they supported the closures or not. Strikingly, the word patients somehow in this entire medical debate only appears like 150 times in these documents. There are way more than 150 documents. Not even every document mentioned patients. The core of the administration's argument was that the capacity of mental institutions in the state was far above what was actually needed based on the findings of the state report conducted in 1966. This data was found so misleading by members of the legislature that even those who supported the closures called attention to its inaccuracies. Still, the administration never backed down from its claims. Speaking of their allies in the legislature, pro-closure legislators were more split in their justification for supporting the closures. While efficiency remained a concern to some, it is also clear that many legislators had concerns other than saving money for the state. Some, like Assemblyman Lanterman, saw the closures of hospitals and the movement to community-based care as a great step forward for the other patients at institutions, the developmentally disabled. And in fact, Frank Lanterman is renowned for all the work he did to help the developmentally disabled, who these reforms did largely improve the quality of care that they got from the state of California. Others thought that the track record and quality of care of private institutions made a movement away from state care viable. Lastly, the strong advocates for decentralized local care saw the closure of institutions as an opportunity to get the funding and support for community care centers that they had been seeking for over a decade. What was largely absent from the records of most legislators were references to the mentally ill. Instead, it seems clear that many figures had their own aspirations for the institution closures, and few of them were focused on how it would affect the care of the mentally ill. The most frequent references to the mentally ill and the quality of care they received came courtesy of the medical community. However, committee hearings and letters to assembly members make it clear that the testimony of medical professionals was neither taken seriously by members of the government or sometimes even heard at all. During one committee hearing regarding the closures in 1972, when the closures began, a representative of the Department of Mental Hygiene dismissed testimony provided by members of the medical community who were opposed to the closures, saying, quote, "Decisions about the continued operation of state hospitals cannot be left to those who can only make ridiculous emotional pleas." Yeah. Lastly, support for the closures by some members of the legislature required that the governor agree to, quote, "let the money follow the patients." For every patient that switched from a state institution to a community care center, their share of funding would follow them. Prior to the start of the closures in 1972, the governor agreed to this budgeting approach. It's even conceivable that this approach to funding mental health could have seriously helped the community centers find their legs as credible sources of mental health care and perhaps save this system. However, after the closures began, and in large part due to the mechanics of California's budget process, which puts a ton of power in the hands of the governor, Governor Reagan refused to follow through on his agreement and instead simply cut costs for mental health programs overall through the closures. In addition, it was at this time that the administration, come on. that the administration began advocating for consolidation of all state health and social services, and a move that would further reduce the budget for mental health care. His justification? There didn't seem to be one other than the fact that the budget in California is largely the governor's domain, and from his perspective, he was saving the state millions of dollars. All this had led me to make a few preliminary conclusions. Most remarkably, the deinstitutionalization movement, which is so often credited as a major force in the great changes that came to California's mental health system, and indeed the changes around the world of mental health care, is rarely referenced in any of the sources I examined in my research. And I'm not just talking about direct references like the use of the word deinstitutionalization or sometimes patients' rights. There's a nearly complete lack of references to the ethics or rights of patients in the mental health care system at all. It's literally not in the vocabulary. Supporters of the closures within government and even the newspapers were not discussing the closures as a humane or inhumane course of action. Instead, they occurred as a result of budgetary politics and debates over the appropriate capacities of mental institutions and communities to care for those with mental illness. This is counter to much of the conventional wisdom regarding the state of mental health care around the world at this time, but upon closer examination, California fits less cleanly in this trend of deinstitutionalization than has been previously suggested by some. While early stages such as the Short-Doyle Act may have suggested elements of deinstitutionalist thinking with movements towards community care and banning involuntary commitments, the decision to close institutions seems more closely aligned with the rise of neoliberal conservative politics, which largely resolved around budget cutting. After all, the governor during this transformation was Ronald Reagan. My research has also shown that there are a lot of different reasons one might have to support the closures at the time, but that crucially, nobody was advocating for the closures as an improvement to care. Even advocates for the community-based programs only did so in the hopes that these programs would then receive enough money to function properly. Once Governor Reagan retracted his promise regarding the money that follows the patients, they had little hope of success. Everyone else endorsing the closures did so for reasons related to budgets or concerns for other communities. Advocates for the mentally ill were largely absent from the debate, and it shows. Which brings me to my last point, and one that feels particularly significant considering how our different levels of government approach public policy today. For decades, California's mental health system has largely failed the people it was meant to serve. The mechanics of that failure, the role of a decline in hospital capacity for the mentally ill, massive decreases in funding, are well documented. My research sought to understand the process of how the decisions to transform the state mental health system were made, and if anyone foresaw the mental health care system failing as it did. What I've found so far tells me that members of the state government were too focused on other questions about budgets, or about how it would impact local communities or other identity groups, such as the developmentally disabled, to really keep in mind the patients the entire system was intended to support. In California and across the country, the debate over how to best support those with mental illness still frequently comes down to budgetary concerns. The past may suggest that these questions aren't the ones we should be asking. In order to once again change our mental health care system, we may have to consider not the fiscal cost of our reforms, but the human cost of our failures. And with that, I would like to thank Professor Thomas LaCour, who was my mentor on this project and was great help throughout the summer. Everyone involved with SURF, especially Crystal, who was also a great help. Jenny Allen, who helped me really brainstorm this project and walked me through writing my first grant proposal of sorts. She's a PhD student in the history department. My sponsors for this research for allowing me to live here over the summer, and all of you all for listening, so thank you.
Questions for Edward? Yes, please.
I know could you elaborate a little bit on the deinstitutionalization and patients' rights movement?
Yeah, it's a very broad movement that encompasses a lot of different ways to advocate for patients. It doesn't just advocate for the mentally ill, it advocates for developmentally disabled, it advocates for people who just have different illnesses, and doctor or patients' rights when interacting with doctors. And it's largely a catch-all term that's used to describe people who are really advocating against mental institutions as corrupt and inhumane institutions, which was a fairly popular sentiment that rose in the early to mid 20th century. And so it was something that I was really expecting to find in the documents I was looking at, was talk about how terrible the state hospitals were, how inhumane they were, stories of abuses, those sorts of things. And they weren't really there. People weren't talking about the ethics or the humanity of these institutions. So it's interesting because it's been used to explain the closure of these institutions before as something that got swept up in this greater movement. But at least in state documents, which is largely what I looked at, and also some newspaper archives, there aren't signs of it.
Yes, please.
Two things. I'm wondering what the voices of objections were when Reagan shifted the deal and said, betrayed the promise. And two, what role, what I had understood the history to be was that psychiatric medicines had come into the fore, and that they could be used to have the patient ambulatory and was out of the institution, and that was the impetus for. Did you find that in the history?
I'll answer your second question first. Most mentions of the improvements in psychiatric care and pharmaceuticals largely came from members of the medical community, both the majority of them who were opposed to the closures and even those who were in favor of them. And they were discussing the improvements in these cares and the great options they provided. But in fact, a lot of the opposition to these closures was saying these institutions were prime ways to really utilize these medications, that these were the right settings to administer them. And then your first question was, the response to Reagan's going back on the deal. It was angry from a lot of people, unsurprisingly. A lot of the legislators who supported these closures were understandably angry because a lot of them thought that the system would still survive and the community centers, and no one was under any delusions that they were going to be able to exist the same way without this funding. But because of how California's budget system works, they write angry correspondences to members of the administration. They say angry things in committee hearings. But the budget system is so much in the governor's power that they couldn't really do anything of real effect to counter it.
They didn't. Just a follow-up. They didn't anticipate that the people that proposed this particular thing. They didn't anticipate the fact that the ball would be in a neocons court.
Apparently not. I think I can almost understand their perspective, because even if you want to take the government take the government more out of mental health care, there would still, you'd imagine, even if someone disagrees with you politically in some ways, you'd want the system to still succeed. And so there was somewhat a sense of surprise, because there was such a sense of doom among some people without these fundings, or without this funding, these centers weren't going to be able to do what they need to do. And it really seemed like they were surprised that the administration would kind of just sink the mental health care system.
Just surprised.
Yes.
From your reading of all the state papers, were there missed opportunities where deinstitutionalization might have been more formally tied to funding for these kinds of community organizations? So, are there moments where it looks like this could have taken a different route?
Well, it's interesting. So it's one of the things I mentioned here. The two key pieces of legislation in the slow trend towards that ultimately led to the hospital closures, the Short Doyle Act and the LPS, do seem to be in line with the institutionalist ways of thinking, and a lot of the arguments used to support them had to do with the ethics of the institutions. Not so much that the state institutions were unethical, but that community centers were more humane, would keep them close to their families, and their communities could, incorporate them back into the communities. So if they were the only trend, or if I was studying those pieces of legislation, there are signs of it. But in terms of the actual closures, the deinstitutionalization movement was largely not present. None of the four, they weren't, I was expecting to find them in newspapers, op-eds, something, but no, and the legislature, the administration, and the medical community weren't really members of that movement.
Thank you very much.
Yeah.